Thank you for joining us. As that just said, we will be recording tonight, so if you would like to not be identifiable, please do turn your cameras off. We're going to give it just 5 minutes before we get underway. If you just bear with us until that time and stay on mute, I'll be very grateful. Thank you very much. Very good evening to those of you who've just joined us. Just to say, we are recording this evening, so if you would like to be non-identifiable, please do turn your cameras off. We won't be sharing the whole recording from now. We'll probably edit it so for about 5 minutes time, but just so you're aware. We'll be getting underway shortly, probably in about 2 minutes time. Okay, very good evening. We are going to get underway. We're still getting people come through in ones and twos, but we're sort of just after 1:30, so we'll get things started. Thank you all very much for joining us for this Get to Know Your NHS event. I'd like to thank all of the speakers who are involved, giving up a lot of their time. It should be a fascinating evening, and I hope everyone enjoys it. A few housekeeping rules first. So first up is, there's going to be quite a few of us on this call, so please ensure your microphone is muted. Cuts down background noise and interruptions. It also makes the recording easier, and we will be sharing the recording for those who couldn't make it this evening. Equally, throughout the entire evening, we will be using the chat function quite extensively. So if you have a question or comment and you would like someone to respond to it, please do throw it straight in there. One of our speakers will get back to you. If not, at the halfway stage and at the very end, there will be time for questions where we'll make sure they're addressed for you. We're trying something new as well this evening, which if you look at the bottom of your toolbar, there is a button called Live Transcript, which should give you an approximation of subtitles as we go through. So if you would find that helpful, please do use it, but it may not be quite as precise as we might hope. And a final health warning, we know in the NHS we can sometimes drift into jargon or acronyms, and if there's anything you'd like clarification on, please don't be shy about asking. Equally, just put it in the chat and a member of the team will get back to you. One very final thing is that there's a lot of different photos in all of these slides through this evening from all over the last year and a half, just to reassure everyone that all of them were compliant with all the restrictions that were in place at the time. So obviously you can probably tell from when they come. So starting this evening, we'll be breaking it up into two parts. In the first half, we're looking broadly back over the last 18 months, some of the highlights of what we've learned during COVID and some of the successes that we've had. At that point, we'll have a quick QA and a break before returning for a look forward. Some of the things we're looking forward to in your local NHS system. Finally, finishing with another QA and closing remarks by our two lead speakers, which is Alex Whitfield, who's the Chief Executive of Hampshire Hospitals, and Ruth Coburn-Jackson, who's Managing Director of Mid and North Hampshire and Isle of Wight ICS. On that note, these are they. I shall pass straight on over to them. Alex and Ruth.
Thank you, Elliot, and thank you everyone for coming along to this evening's event. We've been really keen to showcase some of the work that's been happening in North and Mid Hampshire over recent times. So I'm Alex Whitfield. I'm Chief Executive of the hospitals in Basingstoke and over in Winchester. And I also convene the North and Mid Hampshire Integrated Care Partnership, which is a kind of coalition of people who work in North and Mid Hampshire and provide care to the populations of North and Mid Hampshire. So I'm just going to say a couple of words and then I'll hand over to Ruth. So on the next slide, please. So who are the North and Mid Hampshire Integrated Care Partnership? Well, tonight is predominantly about the Meet the NHS, so it's our NHS partners. But before I talk about those, I'd just like to give a big shout out to our local authority partners. We have Hampshire County Council featured on this slide, but we also work really closely with Basingstoke-on-Dean, Winchester City, Test Valley and Eastleigh councils in terms of how we work together to look after our population. We also work with the voluntary sector and with other partners. Sussex Health, for example, provide CAM services in our patch. But the core kind of NHS attendees of our meetings and our programmes are from the hospital, from Southern Health. Solent have been really involved in the vaccination programme that you're going to hear about this evening. So they've been involved in a lot of that. CAMS, good question, Peter, I can see that pop up. So children's and adolescent mental health services. So this is the mental health team for children and young people, and that's just provided differently or by a different organisation. Most of our mental health provision for adults and older people in the specialist end is provided by Southern Health in our patch for our population, but there's an awful lot that's provided by primary care and GPs and by the voluntary community sector and a whole load of other people. The ambulance service are also really important in our patch and have done some brilliant work around urgent care. And it's good to see some colleagues from the ambulance service on this call too. And then the commissioners and the clinical commissioning groups are also a vital part of pulling the system together. And you're going to hear from Ruth in just a minute. And then we also wanted to give a mention to North Hampshire Urgent Care, who provide out-of-hour primary care services. And again, a really important part of the provision. So we've all been working together, and Hampshire County Council there too, to figure out how can we improve care for our population by working across organisational boundaries, breaking down some of the barriers, the things that get in the way, because I work for the hospital and you work for a GP. And how can we actually say what's the right thing for the individual, for our population, for families, for our communities, wrapping around them to provide the best care we can, but also support them to be, independent and self-directing as well. So I'm hoping this evening you're going to hear some really brilliant examples of how some of our amazing colleagues who work across all these organisations and more have been working together to do the right thing for our people. I'm going to hand over to Ruth now. Ruth.
Thank you, Alex. And as the next slide comes up, you'll see that I couldn't possibly let an event go without putting a map on the screen somewhere. So here you'll see a map of our geography, and it shows our Hampshire, Southampton, Isle of Wight CCG patch and our ICS, which is the Integrated Care System patch, as well as us in blue, which is the North and Mid Hampshire geography. See there listed a few of the things that we've collectively done together over the period, and you'll hear a little piece from each of those programmes throughout the evening. What I did want to do is just start off with to bring it straight into life in terms of some of the stuff that I think we're really, really proud of. And one of the initiatives that is really close to my heart is the telemedicine in care homes piece that we brought together, which involved many of our partners, in fact, across health. And this is innovation that actually started in our system early in 2018. So before the pandemic started, it was early thinking in terms of our system. So we're really privileged to have some forward-thinking clinicians in our geography. And really the COVID piece brought that innovation forward and brought it into life much more quickly. So really it's about a technology advancement that allows us to support people in care homes to provide the very best care for some of our most vulnerable residents within our population without having to move those patients or those residents around the system. So historically, we would have relied on individuals calling ahead to seek care into primary care or into the emergency department to seek that service. And from this point on, we were now able to provide that service through telemedicine or through a technology service. So about half of all the care homes in Hampshire Isle of Wight now operate this service. And so the local care staff can just speak directly into a clinician, a specialist within the hospital, within Hampshire hospitals, to relay the concerns and seek a care plan, which is absolutely fantastic and avoids the resident or the care home needing to make any additional plans in terms of seeking that support. The results really are fantastic. So 72 out of our 73 homes locally report really high satisfaction. And in the first phase of that rollout, we estimate that nearly 250 emergency department attendances were avoided, which of course is fantastic for the individuals concerned, and also really fantastic for our patients who are also attending emergency department, receiving that care nice and quickly, and great for our staff across the system. What I thought I might do, if you're okay, is just to give you 2 direct quotes from a couple of people who, or service users, or individuals who've been involved with this service, just to bring that back to life again. So this first one is from a service user. And she quotes, "My mother truly believes the remote assessment prevented my nan from giving up and dying by being admitted into hospital." So quite a stark piece there, and someone with a really strong feeling on it. Another piece came from a residential home where they called the telemedicine service about a patient who was found with high levels of drowsiness. On the call, there was a discussion with his family about what they perceived as appropriate escalation. The family explained that the resident would not want to die in hospital. The resident had lived in that home for years and loved the staff. The telemedicine service updated the resident's advanced care plan, and the resident was prescribed end-of-life medication so he could die comfortably in his care home. The patient died a few days later at home and with dignity. So that's just another really fantastic example how we can really recognise people's place of residence and think about how we offer care most closely to patients, and indeed right with the patient in that place of residence, not about moving patients around our system. So again, that's a piece that's really close to my heart, and I wanted to share those direct pieces of feedback with you as an opener. And now we'll move on to some other of our really exciting innovations. So thank you.
So thank you very much for the introduction, Alex and Ruth. Our first speaker, Kezia Marshall, to talk about COVID-19 care.
Hello, I'm Kezia and I work for the improvement team at Hampshire Hospitals. I'm just going to give a little trigger warning because there's some stories of potentially upsetting stories of COVID-19, critical illness and bereavement in my presentation. As the second wave of COVID put increased pressures on critical care earlier this year, 3 HHFT staff members in full-time roles with relevant experience volunteered to support critical care in a family liaison role. This family liaison team provided telephone updates and support to families, assisted with face-to-face visits where permitted, usually end of life, created This Is Me patient boards with photos, cards, letters and stories that we could put up at the patient's bedside to provide comfort and tell staff more about the patient's life and personality. During this time, relatives were also offered the opportunity to visit their loved ones via what we called virtual visits, often by telephone, but mostly via video. This included patients who were ventilated and sedated. In 5 weeks, Basingstoke Critical Care completed over 100 virtual visits via video, totaling over 39 hours. I'm going to give you a snapshot of a couple of examples of families who hugely benefited from these video calls and briefly discuss how video calls have been used and continue to be used in other ways on critical care and throughout the hospital. We had a 50-year-old female patient who was ventilated and sedated, whose family were extremely keen for a video visit. She had 4 children. Their mum was ventilated, sedated and not able to respond. We always attempt to prepare visitors before a video call, and we were apprehensive about how they may react. However, as soon as a laptop entered the room, all 4 children were extremely lively and positive, asking sensible questions to the nurse about the equipment that was keeping their mum alive. As their mum started to recover, the whole family benefited greatly from these video calls, and we were thrilled at the rehab aspects of the call. For example, mum trying to speak, move her head, see the dogs, laughing at the family's stories and blowing kisses. Her daughters expressed on the call that the video calls were the highlight of their day. As she recovered on the ward, in a horrible twist of fate, her husband was also then admitted to ICU. My colleague was able to facilitate a video call between the patient, his wife on another ward, their son who was staying elsewhere with a friend as he was only 12 and now both parents were in hospital, and the rest of the family. Once again, the children showed incredible strength of character, and the 12-year-old confidently declared to his dad that everything was going to be okay, that he was going to be asleep for a few days and then would make a recovery and return home. I'm pleased to say he was right, and he now has both parents at home making a good recovery. My colleague firmly believes that the consistent virtual contact that these children had with both parents significantly reduced the psychological trauma for everyone involved. I had the privilege of speaking with this lady's youngest son a couple of months later, who reported that they found the video calls much more useful for them than telephone updates because they could gather more information about what was going on, they could all participate as a family, and they could see their loved ones. He said the video contact lessened the anxiety for them and made the whole situation a lot easier to cope with. When I asked him how his parents were now, he said they were perfect and he couldn't ask for more. One of the benefits of a video visit is that up to 6 people can join the call from different locations. We had a patient severely unwell with COVID who had been repatriated from a London hospital. His grown-up children jumped at the chance of a video visit, and as per usual, we attempted to prepare them beforehand with a very frank call with the consultant and reassuring them that we can turn the camera off if it's too distressing. As soon as the laptop with the family connected entered the ward and they caught a glimpse of their dad, the powerful and emotive sound of their prayers hit the staff like a wave, and the memory will always stay with us. They continued to have video calls every day. Sadly, this man did not survive, and after a few days of video calls, the family were invited on the ward to say their goodbyes. Some of the critical care consultants have found the video software to be of huge benefit other than for virtual visiting. It can allow them to have a face-to-face family meeting and consultation, especially where bad news may have to be delivered, and as a result, the relatives are then more prepared for a face-to-face visit. During one example, a family was so fully informed by this video discussion they'd had with the consultant that they didn't request any further discussions on the day of their visit. They just wanted to maximise the bedside time with their loved one. We quickly determined that what started out as a COVID response was an extremely useful, arguably essential part of critical care life. As the number of COVID patients started to lessen, we did remain extremely busy with non-COVID patients, and we were able to support visits, for example, for relatives who were on the other side of the world. We strongly believe that virtual visiting and family liaison needs to be embedded as part of our digital, innovative, compassionate NHS, committed to supporting our patients and relatives in the best way that we can. Here is one of our critical care patients enjoying a virtual birthday party before she left the ward and made a full recovery. On the left. On the right, one of our youngest critically unwell COVID patients at 33, who we supported to have video contact with his wife. Here they are reunited. This is a screenshot from a video message they sent us to say thank you. The same software we used on critical care for virtual visits and family meeting is also now being used across the trust for outpatient appointments. Where clinically appropriate, next slide please, HHFT are now offering non-face-to-face appointments, usually by telephone but increasingly via video. At the moment, around 30% of outpatient appointments are completed via telephone or video. Since April 1st this year, we've completed over 2,500 video appointments. I'm going to play a short clip of a few of our clinicians describing their experiences with video and how it's been received by their patients.
I think what was really brilliant was that people could see we were actually trying. People could see that we cared. I think people felt so disconnected from the outside world. And actually, when a pediatrician bothered to try and set up to have a face-to-face conversation with them about their concerns about their child, I think they were just so chuffed that we actually bothered. And really, it created a really nice atmosphere whereby people were thinking, do you know what, actually, my pediatrician, his trust, the hospital, they actually care enough about us to try and set up doing something they've never done before. And that was pretty special. It's just another way of doing medicine. And it takes all the good things that we're good at in medicine, and it doesn't diminish them. I think over the telephone, you can lose a lot of stuff. Whereas by video phone, actually, my experience is that sometimes the consultation is better. It's not the same as or worse than, it's better than if I'd seen them face to face. I've got no doubt about that.
I think, you know, the reason that we've gone with video consultations as much as possible is when we're talking about, you know, difficult thoughts and feelings, there's a lot of emphasis we put on the kind of non-verbal stuff. It can be really hard to talk about this stuff, so it's important that we can see each other's faces and as much as possible kind of body language, because that kind of helps us with our therapeutic conversations. So I've found them really valuable for that. Yeah, I think the fact that then I've been able to continue to see people and without needing to use PPE and be in a room and sort of have all of those blocks to that communication. It's also given me a lot of flexibility with when I can offer appointments to people. I guess this is sort of a benefit for me and for the people I work with. I'm not scrabbling around trying to find a clinic room and you know, kind of competing with the rest of my team, and therefore only having quite limited times at clinics that I can offer. I can spread those consultations out, and it's much more flexible. So yeah, I found that to be quite a positive too.
I suppose that's the biggest positive aspect for the patients as well, is continued care during the pandemic. And we're one of the very few speech and language therapy community teams that have been able to give care to their patients throughout the pandemic. A lot of the patients have also commented on parking being really positive, that they've not had to find parking on site. And also the waiting times just are going to be a lot lower the other end of the pandemic, because we've carried on seeing people as much as we can. And the other really big surprise is that the majority of patients who I've spoken to about it have said that they find it preferable to a face-to-face contact. And bearing in mind that the majority of our demographic are elderly patients, I found that quite surprising, that actually they would prefer a video call than having to come into hospital.
There should be another slide here with the telephone just to show you how it works. So for individual patient appointments, patients are sent a link directly to their device. They click the link, complete a few details, and are taken through to a virtual waiting area where a clinician will start the video call with them. It's very simple and easy to use. Patient doesn't need to download any app or software. Since March last year, we've completed almost 4,000 video appointments by over 200 clinicians via this platform. In addition to these individual appointments, we have group sessions via video, which are completed over Teams with fantastic results and feedback. A Health Watch report of June 21 highlights the barriers many face with remote consultations. We understand that, but it also states that we know that remote care has worked well for many and has even removed barriers to accessing care for some who would otherwise find it challenging. For many, retaining the option to access care remotely will be an essential improvement to services, and that's what we want to stress, that we want to provide the option for those for whom it works. We strongly encourage patients to request telephone or video appointments, as most of our outpatient services can provide these as long as it's clinically appropriate. You can find further information on video appointments on our website by going to Patient and Visitors and clicking on Outpatient Information.
Well, thank you very much for that, and some incredible patient stories there, so thank you for sharing. Next up, we have Professor Masamada Kim and Dr. Caroline McKeith to talk about COVID oximetry at home. Over to you. I think it's Matt first.
Thanks very much. And what a terrific talk to launch us. And it was beautiful to hear about the humanistic applications of technology and how we can better serve our patients and our population with the simple things of contact and empathy. We're going to talk about something slightly different. We're going to talk about empathy and we're going to talk about contact. We're also going to talk about the care elements and the deterioration element. And unfortunately, a great deal of that occurred and was required through COVID. Next slide, please. In terms of what we faced with COVID right at the beginning was a lot of patients presenting late with a condition that I'm sure you're aware of now called silent hypoxia, namely the presentation of very low oxygen levels with an absence of significant symptoms and often an absence of breathlessness. Patients unfortunately presented recurrently at a point where their oxygen levels were so low that actually saving those patients became really difficult. So the medical model of waiting for severe symptoms, having developed mild symptoms at an earlier point, needed to be twisted on its head. A new paradigm had to be found that involved interrupting this process of waiting for severity to develop at an earlier point. Next slide, please. So what we worked on extremely hard within this region and within our integrated care solutions was to develop an interruption of the pathway, to identify those at high risk, to give them an empowered pathway that enabled them to self-monitor their trends of symptoms, of oxygen levels, to start administering treatments at home, to ensure that at the first sign of early deterioration, they were able to present to the healthcare system at a point where they could be saved, where they could be salvageable. Because this battle is not one that can be won in a hospital or on a ventilator. This battle with COVID was about education, empowering patients, aligning what we did across the whole care pathway to ensure that it served patients in their own homes. Next slide, please. What we needed to do right from the start was get the evidence together, and this led to the flexing of muscles across our whole integrated care pathway. What happened at home? What happened in ambulances? What happened in care homes? What happened in the hospital? What happened in intensive care? And ensuring that we could get understanding of what the earliest signs of deterioration were in patients' own homes that might give a signal and a clue that a patient was in trouble before the onset of critical symptoms. And what we found was some very early research of 1,200 cases within our region and with Caroline's team in the community was that oxygen saturations were the critical key element, and that saturations of 92% or below was the critical point where you needed to seek help if that was new for you. This led to a national policy change, national safety netting guidance, that was then followed across the whole of England and has now been published by the World Health Organization. During that study, we validated the use of oxygen levels at home, and it became a policy that has now been followed in most areas of the country. Next slide, please. Alongside this, we developed a model for how patients could use oxygen saturation meter readings, how they could monitor their own symptoms for red flags and severe symptoms, who was at risk, and to ensure that patients were empowered to record those levels and know what to do, with education in the form of videos, YouTubes, printed leaflets translated into multiple languages, apps, dashboards and computer programs, and training for our staff to ensure that we were fully on board with consulting and doing these simulated training exercises so that we could give the utmost and best optimal care for patients using virtual technology. Telemedicine, as we call it now. This was about ensuring patients had the power to monitor themselves. Next slide, please. It involved ensuring that patients were aware of what mild was and when not to contact healthcare services, what normal recovery looked like, and what were safe symptoms. Next slide, please. And also what was severe, when to seek help, and with what level of urgency. What were the symptoms that were associated with bad outcomes particularly? When should I call 999? When should I not? What are the bad symptoms to look out for? And ensuring that our system was aware of when the key points of deterioration may occur. We will share all these slides afterwards with all of the links. I know there's too much to read on the slide at the moment. Next slide, please. I would like to now hand over to Caroline, who is right at the forefront of all of this in our integrated care solutions. Over to you, Caroline.
Thanks, Matt. As Matt's really beautifully described, there was an awful lot of work going on at national level. And what I want to talk about is really how we translated that into the North and Mid Hampshire region and what we did on the ground. We decided as a system to come together very early on in the first wave to set up a COVID assessment centre, which was essentially somewhere we could see our potential COVID patients, both keeping them safe, but also keeping the rest of our patients safe. And that was really our priority of the first wave. The team of us that came together, 6 primary care networks covering 230,000 patients. We learnt a lot of lessons in that first wave, but also based on what Matt's already talked to us about, we knew we could do wave 2 better. So in wave 2, we decided again to collaborate, but to come together and provide not only an assessment hub for seeing our patients, but also a COVID oximetry at home service alongside it. This was very collaborative. It was led by primary care, but we worked very closely with our secondary care colleagues. We linked in very closely with the emergency department, our acute medical colleagues. We linked in with the palliative care teams. We worked very closely with our paramedic colleagues because so many of them were involved in going out and seeing patients at home. We linked in with our community nurses. The council were very involved. We had help from the voluntary sector. We had marshals in car parks. We had people at home delivering pulse oximeters. So it was a huge collaborative effort. And back to something Alex alluded to at the start, this is unlike anything I had ever been part of before. We'd never been able to work in such a way across all those different system partners, breaking down all of those barriers. At its most simple, it was a pack containing a pulse oximeter. Patients were given the pulse oximeter and then contacted at home. We had various ways of contacting people. We did have an automated solution that allowed people to be contacted through an app or through a web-based service. But for people that couldn't manage that, it was as simple as a paper diary and 3 times a day phone call. But essentially, people were monitoring their oxygen saturations and being contacted 3 times a day to check in. My absolute focus was this had to be simple and we had to be accessible. So we were able to take referrals, sorry, previous slide please. We were able to take referrals through email or on the phone without any problems. And that my ANPs, my advanced nurse practitioners who were running the service on a daily basis, were checking in with people to see how they got on. And anybody who was deteriorating was able to gain early access to hospital and the therapies they needed. Next slide, please. In total, over the now 9 or 10 months that this service has been running, we've onboarded 1,421 COVID positive patients through the service, and you can see the various waves that we've been working through. We currently have 116 patients active on the service, so this is very much ongoing. Our winter assessment hub that this was co-located with, so this was where we saw all of our potential COVID patients, had nearly 5,000 patients through in the 6 months it was open during the second wave. The vast majority of those patients kept at home and away from the hospital. Next slide, please. The most important thing about running this service, it was set up rapidly, sorry, previous slide please. It was set up rapidly and we had to learn a lot of lessons, and we had to learn those lessons very quickly. It was all about being agile, reviewing, learning the lessons, adapting quickly and repeating. And when I think about all the lessons we've learned, and there were hundreds, they broadly fall into these 4 categories. First of all, having a vision. That was beautifully described by Matt and has been communicated both at a national, also at a regional and local level. We needed something that was simple and that could be well communicated, and that vision was so important. Secondly, the communication of that vision was critical. We had to involve everybody and bring everybody with us, all those partners I described before, but most importantly, the patients. We had to be able to explain to patients why we were doing what we were doing and how we were supporting them. Thirdly, I wanted to talk about action, and in that, I mean, we had an imperfect solution to start with. There was no way we could wait for the perfect solution. We had to get started. And I'm so glad we did get started, because by the time we hit our peak of wave 2, where we had nearly 200 patients submitting data 3 times a day, we were well underway. We'd been running for nearly 3 months. We knew what we were doing by that point. And that was because we got started, and we got started with the imperfect solution. And finally, the collaboration. I've talked about the various partners, but the other people we involved right from the start were our patient groups. Next slide, please. This just gives an idea of some of the feedback we received from patients. We've nearly canvassed about 500 patients so far, and this is just a word cloud that gives you some idea of the feedback we've had. I think it was so important to remember, especially in the early stages of COVID, how frightening it was and how isolating it was for people to be sat at home, knowing that they were unwell with an illness, watching the news on the BBC every night, listening to the statistics. It was a horribly frightening position to be in. So knowing that we could touch base with them 3 times a day and that we could identify that deterioration was so important. And final slide, please. Finally, I just wanted to touch, and I know we're going to come back to this later, about how we learn from what we've done over the last 18 months and how we now take that forward. There are so many options for elaborating on what we've done, using all of this technology and using it in other conditions. COVID was only the start, and we're really excited about expanding what we're doing and taking it further. Back to you, Matt.
Thank you. Excellent presentation. So the million-dollar question, does it make a difference? So when we studied the patients that Caroline had looked after within her unit and assessed how they did in relation to patients that came into hospital without this monitoring, what we found was essentially patients monitored with home oximetry had a halving of length of stay, a massive reduction from 20% mortality within 30 days to about 5%, a halving of intensive care admissions, and a massive reduction in readmission rates. A win-win-win-win for patients and for the healthcare system as a whole. What we found around the world, because this model has been spread, is similar. And in this report from Spain, they found exactly the same, with a reduction in emergency admissions, mortality rates, and length of stay. This is reproducible and implementable everywhere. Next slide, please. This model has traveled, And what started off with a mid-Hampshire collaboration then spread across 7 sites in England, with 8 different collaborators and large-sized spread, to the point where eventually by February 2021, 100% of England had been covered with this strategy. It has then spread via the World Health Organization to 13 further countries and become really global, with countries as far as India now implementing this model on similar lines to what we've done across the NHS, looking after hundreds of thousands of patients at any one time with COVID in a safe manner. Because this isn't as basic, it's about empowering patients with knowledge and with devices to manage their own health conditions. It doesn't require healthcare professionals. What it requires is being honest and open with patients and training them with the best tools to monitor their own health, the nirvana of a future integrated healthcare system. So thank you.
Thank you both very, very much for an incredibly powerful presentation. And must admit, I didn't know half of those stats, so thank you very much. Next up, we have the inside story of the local version of one of the sort of triumphs of the NHS throughout the pandemic, which is the vaccination programme. So to speak on this, we have Sarah Malcolm, Dr. Tim Cooper and Yvonne McQueen. So on that basis, over to you guys. Thank you very much.
Hi, thank you. Thank you very much for inviting me. I'm Sarah Malcolm. I'm the Business Director for the Solent Mass Vaccination Programme. And I'm really proud to talk to you today about the vaccination service that we've had running out of Basingstoke Fire Station since the 1st of February. So we opened February. We've been running a 7-day-a-week service ever since. So we work from 8 till 8, 7 days a week, and we haven't missed a single shift yet in that time. So we've worked consecutively for 222 days. And in that time, we've delivered 152,564 vaccinations up until yesterday. I haven't got today's figures yet, but over 150,000 coming through the fire station, which is just a magnificent number coming through. In my audio, should I turn my video off and see if it's that?
It appears to have just cleaned up at the end there, but yes, give it a go.
Let me try again. Next slide, please. And the next one, please. So as I said, we've been running since the 1st of February. We have had to adapt the service there at the fire station a number of times during the changes. As you'll have heard, the vaccination programme changes daily, by the minute sometimes, and we've adapted the service to meet the needs. So on the 24th of February, we were one of the first vaccination services in the UK to trial walk-in vaccinations, to try and encourage people to come forward at a time that suits them and to really try and make the vaccination accessible in people's local communities. In May, we changed to the service, the scope of the service to delivering 2 vaccinations. So again, we were one of the first services there to deliver AstraZeneca and Pfizer from a single site on the same day. And we saw huge numbers of people coming forward. During the early days, we really focused on supporting our local health and care workers and what we call our local resilience partners to access vaccination. And those are the people that work to make your community safer. So people like Hampshire Fire Service, the ambulance, our schools, dentists, care homes, social care providers, as well as our obvious partners in Hampshire Fire and Rescue. We've developed some really strong partnerships since the service started in February. Of particular note for us is those with our community providers in Southern Health, with the County Council, again, who we haven't worked a lot of since COVID with the Solent service. We were predominantly based in Portsmouth and Southampton, but have stretched into the Hampshire territory there, which has worked incredibly well in terms of partnership working. We also work with our local military establishment and have worked with organisations such as the Farmers Union, to support some of our migrant workers to access vaccination, as well as working jointly with our primary care colleagues who you'll hear from next, and also to support some of our more vulnerable groups in North Hampshire, people like our substance misuse clients, our mental health patients, our learning difficulties patients, who we have all tailored our service for. And of course, I would go amiss to not talk about our partnership with the fire service, which has gone from strength to strength from a health perspective. And they are now an integral part of the Solent vaccination service, not just in Basingstoke, but across Hampshire and Isle of Wight. As an organisation, we have been really privileged to run the service with such an amazing workforce. We've had approximately 1,300 people supporting the service, including 500 amazing volunteers. I can see the slides are blurry. I don't think that's my end, is it? Is there anything Thomas can do around that?
So we're trying to work out what's happening there. It seems to be no particular reason, I'm afraid, everybody. So I think it's good now. So we'll not breathe too loudly.
No problem.
Sorry to interrupt you, Sarah, please.
That's quite all right. I was just trying to make everyone see. So we've had about 1,300 people supporting the vaccination service through the fire station, including over 500 amazing volunteers who work with us, again, day in, day out, 12 hours a day to keep the show on the road there, and we wouldn't have been able to do it without them. We've also had teams in from the Army and the Navy who helped us to mobilise and deliver the service from the beginning. And some of those have stayed on and volunteered with us and still continue to be part of the mass vaccination programme now. And of course, we've also had approximately 30 firefighters who we trained as vaccinators from day one. And some of those still support in their free time now. And it's amazing for us to have firefighters working alongside us. So one of the benefits from the pandemic for us was the huge variety of staff that came to work in the service to either retrain or to volunteer. And we've had such a magnificent mix of people. In the Basingstoke service in particular, we've had a really high proportion of cabin crews working with us, pilots, hospitality workers. We've even had vets that have come and retrained with us, actors, writers, and a number of musicians that have worked in the service. So we've been able to deliver a really successful vaccination programme using a suite of what I would call diverse skills that we in the NHS have never been able to access before and have really come together as a single team with one goal to vaccinate the people of North Hampshire. And lots of those people are now choosing to stay with the NHS, and we've been able to help them retrain. So it's a real honour to have those teams working with us in the fire station. Next slide. Oh, you've already gone on. So over the last 7 months, we've had some great recognition as a team. So one of our clinical matrons from Basingstoke was able to represent her nursing profession at a National Thanksgiving Award at St Paul's Cathedral. Again, meant a huge amount to the team working there. And we were also lucky enough to win one of the Health and Wellbeing category awards organised by Hampshire Hospitals. We've had lots of media interest, as you can imagine, in the service in terms of turning an operational fire station within a few weeks into a clinical vaccination area. We've been on the BBC, we've been in the Basingstoke Gazette, and we've even been able to turn the fire station blue in response to supporting and recognising the amazing contribution that health and care workers have made to the COVID response. We've even had a number of celebrities, well-known celebrities, coming through the vaccination service, ranging from people like Alan Titchmarsh. We've had some of the Love Island stars coming through, for those of you that watch that, and numerous members of our England sporting teams that we've been able to support in a different way, accessing the COVID vaccination. So it's been a real privilege running the fire station. We also, alongside that, run a community outreach service, as I started to talk about, for our more vulnerable members of the community. And we've provided vaccination services out on some of our traveller sites within North Hampshire, where we've been able to offer tailored education and on-site vaccination. We've also worked with organisations and charities such as the YMCA, Women's Refuge, our local homeless service, as well as also supporting some of our ethnic minorities groups, where we've had a presence at recently some of our local Islamic festivals, our Hindu events, and in places of worship. So we've really been trying to bring the vaccination out to people's communities to make it as accessible as possible. We've done some community large pop-up events at places like Winchester Cathedral, which hopefully you'll all have seen about, and we're running the University Freshers weeks come for Winchester University next week. I could go on. There's so much to say about Basingstoke Fire Station. The team have loved every minute of working there. I hope I've been able to give you some insight into the amazing outcomes that they've achieved, not just for the mass delivery of vaccination, which is our primary objective, but also on an individual basis, where we've truly made a difference to some people's lives to access the service. People have recognised the fire station as a place of safety, and our team is a bunch of clinical experts. And we've had numerous people come forward for non-vaccination conversations because they recognise the place of safety. So as part of our clinical assessments, we've been able to support people through safeguarding issues such as domestic abuse, where they felt able to come forward and speak to our teams, through mental health crisis, and through signposting to other areas within health and care. So it has been a real honour to be part of the programme. As you'll know, the service is closing on Friday, so our last vaccination happens on Friday afternoon. All been an emotional week for the team there, but we are really looking forward to continuing to provide a vaccination service in North Hampshire. I'll pass over to Tim.
Amazing, thank you, Sarah, and what comprehensive kind of coverage. I can't add much to that. I thought really, if we could just get back a slide, if that's okay, just kind of talk about kind of what it felt on the ground. I think all of us have been touched by vaccination in one way or another, either by visiting sites, getting stuck in, knowing people that have been involved in it. I just would really kind of take you guys back to how it was back in sort of November, December. So really kind of very early doors. Remember, at that point in time, we'd just come out of a sort of a mini lockdown before we went back into a Christmas lockdown. And we had very short amount of time to get things organised. And one of the things that unfortunately we recognised within general practice is we don't have a huge amount of space to be able to do this. And this was a piece of work that had to sit on top of the bits that were going on in the background. So that first picture there you'll see is the kind of the first GP-led site that we operated. So out of the Hampshire court, which served us incredibly well over that period. And I just thought I'd walk you through a couple of the pictures really, just to see sort of what it takes to sort of take things through. So we kind of set up a dedicated call centre to be able to take some of the pressures off practices. The team you'll see in the bottom right there are our receptionists coming in on the weekend to help book our first load of patients. A lot of you will remember back to those dizzy days at the very start where it was quite challenging to know which group we were going to do and when we were going to get vaccine. So we had to move quite quickly and effectively. And that was a great example of primary care stepping up to the challenge really, in our teams, and particularly front of house teams, our reception teams who have a particularly challenging time. They really helped us there, get those people booked. And really, we had about 2 weeks or so to turn effectively a ballroom into a vaccination hall using a kind of a grid layout. And again, it was just an amazing achievement for everyone from general practice to kind of get stuck in and get involved really. I think Caroline mentioned earlier about the relationships that helped develop the COVID oximetry at home being born out of working together in the COVID assessment sites, and the success of the vaccination programme for the GP-led sites has definitely been born out of that as well. It was ultimately a group of friends trying to work together to solve a tricky problem. Next slide, please. So I wanted to talk a little bit really similar to how Sarah did, just about the kind of the people that have been involved. Next slide, please. We've been able to kind of be supported hugely by people in and around our community. And I think if there's one point that I would just really hammer home is that none of what we've achieved would have been able to be done without the support of our community stepping up to help for us. So the local Rotaries organised themselves with impressive speed to organise a rota amongst the local Rotaries to come and help initially through all sorts of weather, including quite heavy snow. We've been massively supported by the Basingstoke Voluntary Association that have coordinated our local people wanting to help and get stuck in, ensuring that they're vetted appropriately and can be directed to the right place really. We've also had huge support and encouragement from our local councillors, MPs, our other secondary care hospital colleagues, and we also invited some of our military friends that we knew to kind of come and help get stuck in as well, which was fantastic. But also a huge big shout out to the guys actually from the CCG. So I think they often sit in the background, they're busy making sure that everything happens and they don't get celebrated enough, but we really couldn't have made this work without their continued support even now. So thank you to all of them. Next slide, please. And as many of you all know, it wasn't just vaccinating sort of our patients. So initially when we started, it was bringing people in, and often that was the first time they'd been out that year, was to come and see us. So it was a real privilege to be there. And some of you may recognise Dr. Decker, who's now sort of taking on a more sort of regional role, but also vaccinating some of our staff there as well. So that chap sitting down in the middle there is one of our drivers from NHUC, who was absolutely fantastic. And it was a real privilege to be able to get early vaccinations into that team. And the group below is a group of slightly battle-wearied primary care clinicians, their reception staff, anyone that they could grab at any point to come and help get stuck in. So it really was people pulling together and just trying to make it work. Next slide, please. And the vaccination itself has kind of gone out very similar to the work that Sarah's team have done. So we've offered outreach clinics as well to our more deprived areas, as well as visiting areas for our homeless and our drug and alcohol services to try and increase the uptake. I put this picture up partly because I think it's the only time I will be celebrated in the Daily Mail. So this was at one point, I think we made top 6 or top 5 maybe, of sort of CCGs with uptake areas. That's my mum's proudest moment as of now, was that sort of celebration in the Daily Mail. And again, the vaccinations continue to work really well. Next slide, please. In terms of where we're up to at the moment, so I sent this through at the end of last week. We've actually just crept over 188,000. You get these lovely little charts about kind of how we've been doing for vaccination, and you can see it's been ongoing since sort of the start of December, really. And really looking forwards, we're going to be carrying on very much as we are. So we're working very closely along with Sarah and her colleagues to continue to deliver vaccination. We await further information about boosters. As soon as we know what's happening, we'll be able to get started with those. We are very well prepared in our new site at Jameson House. So we're looking forward to getting stuck in, and we've been ably supported again by our colleagues stepping up and our volunteers helping us. Next slide, please. And I think just one of the things I would reiterate that, you know, and we get very obsessed with sort of numbers, and the NHS loves sort of numbers, but I think it's the small bits that sit behind this. So we've had lots of lovely things from people, sort of letters coming in, and really just it reiterates the impact. But again, if we follow the science on this, actually the vaccination program in itself is making a huge impact. So aligned with the fantastic work of people like Matt and Caroline with the COVID oximetry at home and all of those things, it's all helping us manage this challenging thing that is COVID, and helping us make hopefully get a little bit closer to normality. But what we've seen is it's reduced infection rates, and it's also reduced spread as well. Next slide, please. And so really, I just wanted to kind of finish with thinking forwards. So, I mean, what I would say, I've only been around in these sorts of roles for about the last 3 years or so, working as a qualified GP. And for me, this has been the thing I've been most proud of, and it's it makes me most proud because it's really worked within the community and for the community. So this is Basingstoke and its surrounding people in North Hampshire and across Mid Hampshire as well, working at their very best. It's us supporting each other. And it's really got me thinking about how we work better with you as both our patients, but also as partners in our health. So I'm sure over the next few years, as we move towards being an integrated care partnership and system, we'll be getting much more involved with all of you. Thank you. Over to you, Yvonne.
Thank you. It's interesting listening to those two presentations because so much of the experience mirrors our own experience at Hampshire Hospitals, and reflecting on putting this together seems so simple now. We pop up a vaccination clinic all over the place, but at the time when we were asked to do this, it was really, really challenging. Next slide, please. So again, we were asked in November with 2 weeks notice to get ready to get a service up and running. So lots to consider at that time. We were codenamed Talent and Courageous. We didn't know anything about vaccines that were coming. At that point, they hadn't even been approved. We had rumours of freezers at -80 and logistical challenges of actually managing the process of moving vaccines around. We had to think about space. And again, a similar experience in having to commandeer space in our education and conference centre, putting down flooring and building pods to actually create space to make this happen. Thinking about our staff and where we were going to find our staff. Back a slide, please. and thinking about where we were going to actually get our staff from, given we were so overstretched. Many things to think about as we started to put this together. Next slide, please. In January, we opened up the service. We got going, a little bit of a delay, but we managed to get the services open, the vaccination centres open across three of our three sites at Andover, Winchester and Basingstoke. It was extremely challenging. Our booking system crashed due to the demand, which was a real positive because that had been a concern. But again, everything was being developed on the day and on learning as we go, as we were trying to develop the systems to actually help make all of this happen. But it was fantastic. That staff were patient, they were engaged, they were enthusiastic and wanted to come and have their vaccinations. And our focus at this stage was very much on health and social care staff. So really protecting our healthcare staff was a real priority at this early stage. Next slide, please. So by February, we were rattling through our Hampshire hospital staff and students, and the system was really starting to increase the capacity, as we've heard about at the fire station. And we were now starting to focus on social care staff. And they were a hugely diverse group of people who didn't work for us, but we had to try and track them down with our social care colleagues. And they were community pharmacists, volunteer drivers, people worked in specialist schools, funeral directors, people from all sorts of walks of life, bringing them to our centres to give them vaccinations. And we were also in a position at that stage to start thinking about our clinically extremely vulnerable patients, so we could offer them a very controlled environment for them to come and have their vaccination in what seemed at the time a sort of smaller and more intimate environment where we could manage any particular risks. Next slide, please. So by this stage, we sort of got through our first round of vaccinations, and in March, we began with our second doses. Just to give you some idea of the figures there, smaller numbers than the bigger vaccination centres, but we operated on a very sort of short hit of vaccinations. So over 24,000 vaccinations were actually delivered. So that is in the region of just over 8,000 of our own staff and students, and just over 4,000 staff from health and social care outside of the organisation. We managed to vaccinate within that period, of which we were only actually functioning for 8 weeks all in. Over 90% of our staff actually received a vaccination. And one of the things we were keen to do and manage across the system was make sure we didn't waste dosage. So every dose really needed to count. And certainly our wasted dosage were really, really low, as we managed to squeeze our 6 doses out of those initial predicted 5 from the bottle to try and make the most of everything. We had over 175 staff involved in this, and 1,420 hours of actual vaccinating across a 7-day week. We also dealt with massive numbers of COVID queries of people with their own stories, trying to work out what were the best options and safest options for them. Next slide, please. But there were challenges and there was learning. That word uncertainty that I just heard Tim mention as well. It was so much uncertainty at the time, and the team working and communication was a really important part of actually trying to manage that, not just for the staff who were involved in this, but also for the staff who were coming to receive their vaccination. Our old favourite in the NHS, data and data systems, were really challenging. And again, I think we've learned a lot about how best to sort of have visibility on that data and be able to take intelligence from that to inform us going forwards as we go into the planning for boosters. It's challenging matching supply and demand, and that's where the system came together to make sure that the people and the vaccines were in the right place at the right time. And at times we moved vaccines between us to ensure we were minimising waste. And the biggest stage for us now really is thinking about, the going forwards. How do we make this business as usual as we plan for boosters and future campaigns in what is already a very challenged environment? Thank you very much. I'll leave it there.
Gosh, well, thank you all three. As I said, the vaccine rollout has made a lot of headlines, but it's fantastic to see sort of what was going on behind the scenes. I hesitate to call it a sausage factory, but sort of all the masses of logistics that came together to make it happen. So thank you so much. So we're at the stage for questions on our first three, and I've been keeping an eye on the chat, and there's been lots of things going on back and forth, but I think there are two broad areas, if I could pick them out. Kezia, both for you, if that's okay. So the first one is more generally about the limits of telemedicine, perhaps, and maybe patients wishing to go another route. So if it's all right, could I come to you first?
Hi, yeah, so when we were at the height of the pandemic, it was requested that we do as much as possible non-face-to-face. So there was a very sudden switch to telephone, mainly telephone appointments and some video. Our aim now is to do non-face-to-face where clinically appropriate and to offer patient choice. So we're not mandating that it has to be through one format, unless, of course, you need to be seen face-to-face because of what your appointment is about.
Fantastic, thank you very much. The second question was around e-consult and the frustrations of having to repeatedly share the same information with different providers. I'm not sure who the best person might be to come to. Kezia, is that still you? I hate to pick
so
on
we
you
don't
twice.
use e-consult at the hospital, so I would have to ask one of my GP colleagues to comment on e-consult.
Do I have a volunteer?
I can talk about it, Elliot.
Thank you, Tim.
No trouble. So obviously, online consultations are a relatively new thing within general practice. It's something we're still getting to grips with. E-consult is one of the providers that we use. Describing it as probably it's the best of all of them, I would probably say, and we're still working out how best to utilize them. And I completely recognize the frustrations that everyone has when you have to enter the same information over and over again. Unfortunately, at this point, there isn't any kind of direct linking into the sort of the patient data. What we're hearing from eConsult is that is due to change with coded data happening. So I think if we ask this question again in about 2 or 3 years, it will hopefully a lot of those challenges will be addressed. What I would say from a clinician perspective is we do find it as a useful adjunct to the way that we work. So absolutely, like all these things, it needs to be a blended model of how we work. So it can't replace everything, but similarly to our colleagues at HHFT, it's allowed us a different way to access some patients, and we completely recognize it works for some, but it's not going to work for everyone. And I think it's just about how do we use technology sensibly and safely as best we can to support people, and where it doesn't work, we think about another idea, really.
Thank you very much. Seeing no other questions in the chat, please don't worry about, we can put them in at any time. I'm going to suggest we move on. Next up is our scheduled break. Given the timescale, I'm going to suggest if we go straight on through rather than taking a 5-minute pause, unless there's a strong feeling the other way. And just let me know in the chat one way or the other, or I will go straight on through. Okay, in that case, if we could share the slides again. Thank you very much. So next up, we have Dr. Matt Nesbitt and Katrina Mason to talk about what's going on behind the scenes on a busy day or weekend. So I think, Dr. Nesbitt, you're first.
Thanks, Elliot, and good evening, everybody. So the topic that you've asked me to talk about is urgent and emergency care, and of course, whilst Tim and colleagues have been doing all of their fantastic work with the vaccination programme, our day job as GPs hasn't gone away, and of course we've had to manage all of the usual day-to-day business, I suppose. When we talk about urgent and emergency care, a lot of people's first thoughts will be of the emergency department at the hospital, but I think it's important to talk about what happens outside hospital as well. And outside hospital, we have a large number of organisations looking to provide care for our patients who need things very quickly or need things on the same day. So that network of organisations will include some places that people are very familiar with and some that you might be less familiar with. So things like pharmacies, the 111 service, the out-of-hours service, the ambulance trust, our district nurses, community mental health teams will all contribute to looking after people who need urgent and emergency care. It's very tempting in talks like this to talk about our aim as keeping people away from the emergency department at the hospital. And whilst that is, of course, one of the things that we're aiming for, I don't think that's what I don't think that's what we come to work for, really. I don't think that's what makes us get out of bed in the morning. I think the thing that really we're trying to do is to make sure that people get the right care in the right place at the right time. And very often for our patients, that care is right to be provided at home or closer to their home, like in a GP surgery. And of course, our emergency departments and hospitals are enormously important, and Katrina's going to talk about those in a moment. I thought it might be useful just to think about the kind of patients that we see as GPs and in the community. So there were a couple of kind of patient portraits that I was going to share with you. So one, for example, might be a 1-year-old child who on a Saturday morning develops a cough, and by the afternoon and the evening has started wheezing and having difficulty breathing. So the parents of the child call 111, and the call handler decides that this person needs to be seen in an out-of-hours GP service. And unfortunately, the out-of-hours GP thinks that the 1-year-old doesn't need to go into hospital, but can be managed at home. And one of the services that we have available to us at the moment is a service called the CHATS service, which is the Children's Home Assessment Team, who will offer telephone support to parents. And if children need visiting at home to be reassessed, there are children's nurses who are able to go out and reassess children at home to see whether or not they're still able to be managed at home, or whether or not they need to come into the hospital. Another little patient kind of vignette I thought I'd share with you was somebody maybe in their 90s at the other end of life, whose carer notices that their catheter's not draining very well. Again, a call's put into the 111 service, and a visit's arranged by the district nurses who are provided by our colleagues at Southern Health. The district nurse visits the house and flushes the catheter, but thinks that the patient needs some antibiotics as well. And so they liaise with the out-of-hours GP to arrange a prescription. And I hope that what those kind of brief stories illustrate is that what we're trying to achieve is that all of these organisations work together to provide support for our patients at home and in the community. What we're not trying to do is give people the feeling that they're being passed from pillar to post from one organisation to another. I recognise that we don't get it right all of the time, but that's what we're trying to achieve. Just to give you some sense of scale, as GPs, we see somewhere between 1 and 1.5% of our patient list every day. So that equates to somewhere between 5,000 and 7,000 appointments a day across North and Mid Hampshire. It will vary from practice to practice depending on how they operate their system, but the kind of general reckoning is that about 2/3 of GP demand is kind of routine appointments, and 1/3 is urgent problems. So quite a significant number of people that we're dealing with. SCAS, who provide the 111 service, deal with between 330 and 350 calls a day, and only around 10% of those will end up in the hospital's emergency department. So overall, whilst things I'm sure are busy in the hospital and feel busy in the hospital, we're certainly doing our best to manage people in the community as well. Moving forwards, as Matt Inada Kim has said, I think our nirvana would be a more integrated healthcare system, and we're certainly looking to work more closely across our system to try and avoid that kind of silo working that we've seen in the past. Katrina is going to talk to us about what happens when our patients do have to visit the emergency department now.
Thank you very much, Matt. Hard act to follow. So patients don't just decide to come into the emergency department. Most patients that end up in the emergency department have started their day off quite well, and something has gone drastically wrong, which has meant that they've ended up with us in the emergency department. But every day is different in the emergency department, and we respond differently every single day to the challenges that come through the door. There's never any right or wrong, black or white answer to what we do within the emergency department, because it very much depends how many patients are coming through the door, what's wrong with the patients coming through the door, what does the rest of the system look like? Do we have flow out of the emergency department? Do we have flow out of the trust? What does the rest of the patch look like, the other hospitals and trusts included? All of that feeds into how we respond within the emergency department on a day-to-day basis. Now, we've been incredibly fortunate throughout COVID that so many new initiatives have come forward, and we've really been forced to think about how we can do things differently, including in the emergency department. Now, the first thing we had to do was expand the department because we have to adhere to social distancing and ensure that our patients are safe. So we've expanded it, and then we had to think about, well, actually, how do we do these safety checks when patients come through the front door? And as they get to the front door, how can we use and improve our pathways to ensure that if they are going to come into the emergency department, we can get them seen by the specialities quickly and the correct specialities. So we've updated many pathways within the emergency department so that once you're into the department, if you are a lady who's having a miscarriage, we can very quickly get you over to the speciality that is best prepared to care for you, rather than have you sitting and waiting in the emergency department to see an emergency department doctor to then be referred on. We try and do it from as close to the front door as we can and move those patients over. We're currently working really closely with the 111 service, and that's been really great for us, because actually if we can try and give a patients appointments to turn up, then we can reduce the number of patients that come to us in huge bulk amounts. It's much easier for the emergency department to deal with trickles of patients coming in rather than a busload of patients arriving at one time. So working closely with 111 and the clinical comms centre, that's meant that we've been able to put in some arrival times for patients, and that works very well for the patients as well as the staff that are treating the patients, and goes on to enhance the patient care that we can provide. We're also now looking at a new system so that when patients turn up at the emergency department, we're going to be looking closely at an iPad system where you'll be asked some safety questions and some clinical questions, and the answers that you put into that system may help us redirect you to a different service. So it might be that we can get you to a pharmacy, it may be that you're better seen by a GP service, it might be that you're better going to the Andover minor injury service. So this is a new service which we're looking forward to introducing over the next couple of weeks to see what results we get from that service as well. We've put an awful lot of work into recruitment and retention, because we've realised that with increasing numbers of patients coming through the door, it's really important that we are upskilled on those patients that are coming through. And we have noticed a slight change in the demographics of patients coming through, and we are seeing some patients who are much more sick than we've previously seen before. So they're requiring our resus rooms more. That means that we're really upskilling the nurses that we have working in our resus areas. Minor injuries have gone down slightly because of COVID, but I think that's because schools were out for a long period of time and we didn't have so many events on. We are expecting to see those go up in the coming weeks. But what we're really proud of is the great practitioning teams that we have throughout the trust. Minor injuries in Andover, and we've still got our practitioning teams in Winchester and Basingstoke. So we've got a great service there, which is really moving forward. We're moving forward with IT systems within the emergency department, which will actually integrate us better to the rest of the trust and give the rest of the trust a better understanding of what's happening in the emergency department as well. We've introduced new huddles, which mean that our first huddle at 8:30 in the morning is about what's happening within the emergency department, what's happening within the trust, but what's happening also within the bigger system of the surrounding areas and our local partners. These continue throughout the day, so it's never just a morning and an evening huddle, but we've got various huddles which ensure that throughout the day we've got continual communications about what we might need to do and what we might need to change and adapt throughout the day to ensure that we remain safe and effective coming through. There's lots of things going on in the background, and we're looking at developing more pathways. We're looking at emergency villages and how they may help patients and staff ensure that patients are seen in a timely and efficient way. So lots going on within emergency care at the moment, but we couldn't do it as a standalone unit. It's been incredibly important to have the input, and will be incredibly important to have the continued input of our partners across the whole area, because that input will ensure that we get it right for the patients coming through. Thank you.
Thank you very much, both Matt and Katrina. Next up, we have Mental Health Introducing a New Service. So Elvita Bailey and Barbara Allen, over to you both. Thank you very much.
Thank you, Elliot. Good evening, everyone. We are really excited to have the opportunity to spend a few minutes to talk about this new service available to North and Mid Hampshire residents. So this is a new mental health safe haven service. Next slide, please. The service opened its doors on the 1st of September, so only last week on Wednesday, and has already been accessed by a few individuals in mental health crisis who have just turned up at the centre or have called the free phone number that's available. So why would you decide to commission this service? Next slide, please. As the pandemic was developing, we as a mental health commissioning team conducted a gaps analysis to look at what mental health crisis support was available in Hampshire, Southampton and the Isle of Wight, and to compare the different areas. So within our North and Mid Hampshire footprint, we know that we still have available the psychiatric liaison service at Hampshire hospitals, both in Basingstoke and Winchester. We have got a mental health crisis team available, both services delivered by our colleagues at Southern Health Foundation Trust, and they're both 24/7 services. We also know that we have available various crisis helplines, national and local crisis helplines. But what we were seeing is that some other areas had some extra support for crisis in the community. So you might know that in Aldershot there is a safe haven service. There is a safe haven service in Southwest Hampshire in Havant, and also Southampton have got Lighthouse service, which again offers crisis support in the community. And actually what people were saying to us, that when the crisis services are most needed, and evenings and the weekends, availability is limited. And actually patient and carer groups were actually also saying that they don't want to go to emergency department for a mental health crisis. They don't want to call the emergency services. They want their crisis managed and supported in the community. And I suppose the last thing to mention is that, you know, this is not news to you. I know that we've seen during the pandemic an increase in a range of mental health conditions. So people have suffered uncertainty, as most of us have seen in the presentations. People have been uncertain about their jobs, about their finances. People have felt isolated. Their support networks suddenly weren't there anymore. Their family and friends circles of support that are so crucial to managing our mental health, they weren't there, or they were minimal. And also people have experienced loss during this period of time. So all these reasons came together for us to commission the North and Mid Safe Haven service. Next slide, please. So what is the Safe Haven? It's actually what it says on the tin. Next slide. So the aim of the service is to reduce the emotional distress of individuals and their carers, and that's important. The carers are important in this process, and to support individuals' recovery and to support the individuals to manage their own crisis in the future. Some of the objectives of the service is, you know, as I already mentioned, offering an alternative to attending hospital for anyone that's experiencing a self-defined mental health crisis and their carers. And the objective of the service is to offer a safe, supporting and therapeutic environment. And that's really crucial. I think people have been telling us they don't need a medicalized environment to manage their crisis. And we've kept that in mind when we designed the service as well. The service will support individuals to de-escalate current crisis, but also will work with individuals to prevent crisis from happening. So if somebody is feeling that all the conditions are right for them to go into crisis, they can contact the service and the crisis can be de-escalated or prevented at that stage. The service will empower the individuals to identify their own needs, make their own choices, and develop their own coping strategies that make sense for the individual actually. And it will do that by using individual strengths and talents. This is a proactive service and is a hopeful service. It is crucial to say that this service is a partnership between the staff running it, individuals and carers accessing it, and all statutory and non-statutory organizations. It's not a one-off stop. People are really cared for. They are signposted to most appropriate services, and they offer support with their, let's say, in hours preventative side of mental illness as well. And another key point to make is that one of the objectives of the service is to ensure access to mental health crisis support for those groups and individuals who might not traditionally access mental health services. So I'm mainly talking about ethnic minority groups, and this will be one of the objectives of this service. So I'm going to pass you on to Barbara now, who will talk to you about how you can access the service and what the staff complement is.
Hello, so thank you, Alvetta, for that. I'll tell you a little bit about the North. We're calling it the North and Mid Hampshire Safe Haven, but it's actually located in Basingstoke. As Alvetta said, we have walk-in service users attending. We also have a free phone number, and that's acknowledging the difficulties in people perhaps getting from Andover, which is the other main service user population that we want to address. So the North and Mid Hampshire Safe Haven is delivered by Andover Mind. We're a county-wide local mental health charity. In partnership with Southern Health Foundation Trust, the Specialist Mental Health Trust. The service is available to all those who are 18 years plus in a self-defined mental health crisis. And I think that's important to say, that it isn't a crisis as defined by the mental health professionals, it is a crisis as defined by the person themselves. It's a 365-day-a-year service, open from 6 till 10 p.m, 7 days of the week, including bank holidays. I know that service users particularly find it difficult to access support over bank holiday weekends and over weekends themselves, and the service will be available for them. Access by walking in or by ringing the free phone number. So if you wanted to write this down in case you or any of your friends, family want to access the service, I'll also put the number in the chat. There's a staff team of mixed experience and skills. So we have nurses, we have support workers, supported by the clinicians from the crisis team. And also peer supporters are available, and they're a key part of this service. So next slide, please. So I wanted to talk a little bit about the importance of lived experience of mental health. So for service users, there can be a benefit of talking to staff, or in this case, peer supporters who've experienced mental ill health themselves, including mental health crises. There's the ability for the peer supporters to build rapport with the visitors to the service, share coping strategies, help them navigate the mental health system, which can be quite complicated for people who perhaps haven't accessed any services in the past, and can help to demystify mental illness, especially for those experiencing their first crisis. Service user feedback, and we carried out service user feedback in both Basingstoke and Andover in the wellbeing centres and in the wider service user population. Reported that sometimes they want a listening ear, but they want one that is non-judgmental, and I think that is something that the peer supporters can really provide to the service. Next slide, please. So it was definitely a co-design process. So it was a group of interested individuals and organisations who formed part of a steering group, as well as people with lived experience and carers. And we looked at similar services, as Alvetta has said. There is a safe haven in Aldershot, there is one down in Southampton and one in Havant. But we wanted to address the needs of the Basingstoke and Andover populations particularly. And we listened to and collected the views of those using their current mental health services, and feedback was directly built into the service specification. And we ensure that the service links in with all other mental health and social care provision, so both statutory and voluntary sector. And there will be an ongoing review of the offer led by those accessing the service, and also regular review of the outcomes, because the service is only as good as the feedback that it gets. And I think that is apparent from the chat tonight. The feedback is always valuable, whether that is of a negative experience or a positive experience. Thank you very much.
Well, thank you very much on a very, very important topic. And our final presentation tonight, Healthy Communities. So Helen Cruikshank, Ali Young and Jessica Berry, over to you. Thank you very much.
Thank you very much. And I'm going to start off here and then hand over to Jess. So I'm Helen Cruikshank and I'm a public health consultant working with the North and Mid system. And we've heard this evening about some really great examples of services and programmes available to our local population when they are in need of support. And we're going to finish the session today by looking more broadly at our communities across North and Mid Hampshire and how we're working together to help people stay healthy. If I could have the next slide, please. Thank you. So when we're thinking about working across communities, and by communities we can mean anything in terms of how people relate to their own communities. So that could be a collection of streets, it could be a town. But of course, working across communities doesn't come from just one organisation, but a network of organisations working together with local people. And we know that there's lots of different factors that affect people's health. So it's not just the health services that are there, thankfully, when people are ill or have a specific health problem, but where we live, what we eat, what we learn at school, whether we have a job, and many other factors affect our physical and mental health. As you can see from this slide, all of those different aspects all come together to determine our health. Next slide, please. So when we're talking about healthy communities, we need to collectively take action across all of these different elements, as there's not just one thing that will make a difference. And we think particularly about two elements. Firstly, about preventing ill health, so ensuring that people have the opportunity to lead healthy lives. And of course, this is much bigger than simply making healthy choices, for example, not smoking or not drinking too much. It's really recognising that health comes from a complex range of factors that start even before we're born. And secondly, we're thinking about what we refer to as health inequalities, so whether some people experience poorer health than others and whether that's avoidable. So through the pandemic, we've learned how some groups have been disproportionately affected by COVID-19. For example, people from certain ethnic groups or people who work in particular jobs. This isn't new, and it doesn't just apply to COVID-19, but the pandemic has really raised awareness about the critical importance of addressing avoidable inequalities or differences in health. And to understand the health needs of our local communities, we use information about the population from published data. For example, as you can see on this slide, we know that there's a difference in years spent in good health. That's in the box referring to healthy life expectancy. That's about the years spent in good health. And there's a real difference between our most and least deprived communities. Also that smoking continues to be a key cause of early death. So these facts we know, but really to understand the needs of our communities, it's not just about data and services. We want to learn from people in the communities and people that live in our areas. So I'm going to hand over to Jess to talk about what we're doing around healthy communities and how you can get involved.
Okay, thank you, Helen. So what we've done so far is we've been working very closely with our business analytics team and identifying areas where there are poorer health outcomes and often with increased behavioural risk factors. These areas are often in areas of deprivation. However, we shouldn't forget that there are areas that may not come up as high deprivation, but we may have more older people and more frailty needs. So the areas we're currently looking at are Andover and some particular wards in Andover, and Buckskin, which is a ward in Basingstoke. So we've actually got 2 stakeholder engagement group, and the stakeholders are made up of the statutory sector, the voluntary sector, leisure, district councils, all sorts of people. And what we've used those stakeholder groups to do initially is to map the assets in them communities. And when I talk about assets, I refer to people, places and spaces. And when we're thinking about people, it could be the individual volunteers that work in that community. You'll see there's a picture of someone working in the Andover Food Bank. It could be a collection of people that are from a voluntary organisation. It could be people with skills and leadership. And places, the obvious places, we've got King Arthur's Ward, which is a picture there, which is a good community centre there, but that could be a church. And it's thinking of places that, you know, are available to community. And also I've put in spaces. When we usually think about space, we might think about a building, but actually space could be a green space. Also you'll see in the bottom corner there, there's what we call the life bus. And that's a space that's used as a roving model to go into communities to help with digital and education. So yeah, thinking outside the box in terms of space. I think Tim also mentioned earlier, we've done lots of stuff around inequalities and the vaccine programme, homelessness, substance misuse and BAME communities. We've also got our social prescribers now working in primary care, but not just in primary care, we have also got them on the high street. So that's really embedding into the community. So the next slide, please. So we've done quite a lot of work in the last 6 months, but where do we want to go now? So we've got some great patient participation group members. Many of them are on the call today, too many of them to give an individual shout out, but hi. So what we do want is to broaden our reach to patients and have people from, you know, all sorts of a broad range, including children and young families we'd like to hear from. So that's something we'll be working on in the next 6 months. We've got Elizabeth Kerwood and Nick Brooks that help us with our community engagement and innovation forum, where we reach out to system stakeholders. We're also working closely with our district councils on their health and wellbeing boards or partnerships. And sort of hot off the press, something we were looking at more recently is how we can enable communities to any initiatives they've come up with that are sustainable and ongoing, and that we don't go in, help them out and then walk away. Is actually want to give the communities the leadership capabilities to be able to be communities within their leaders within their communities. So that's something we're currently looking at. We're going to continue to have community engagement events and listening events, and to co-produce any initiatives with the community. So I'm going to hand over to Ali, and I think the next bit might be quite technical, so we may need some comms support.
Thanks, Jess. And some great participation from our audience. So we're really keen if everyone can just reach to their phones. I think we've heard lots about how we've embraced technology tonight and how it's helped with our access to care. So we're hoping that tonight you can help us access the voice of our community a little bit more. I think we've just lost that slide. So building on what Jess has said about us wanting, we really are trying to change the way that we think about designing our services, building on all the great work that we've done with the community, and thinking about the collective effort that we have together and giving you guys control. So it looks like we've already got some really good participation, but if you can either take your phone to the QR code or equally go to your web browser on slido.com. This is challenging for us, so this is live adaptability of the NHS in real life, but we'd like to ask you to think about yourself and think about what makes a difference to you, what matters to you, and what helps you have a good day, what helps you with your well-being. Help us design services that really do make a difference to individuals and to our communities. So fabulous. We've got laughter. Laughter is definitely, I think, laughter's got many of us through the last 18 months, I think, particularly from NHS colleagues, contact with family and friends, and we've seen that really come to life in terms of some of the design of services tonight. Love to bottle some sunshine. I've certainly had that. I think I might have had enough sunshine today, actually, with the heat wave that we're under. But that's fantastic. Please do, the Slido will continue to be live from my understanding, so please do continue to put your information in there. And then secondly, we would like you to think about what's the biggest impact on the well-being of your local community. So our North and Mid Hampshire is a really big geography. It's a really diverse geography. We've got towns with deprivation and affluence and so much going on that we really want to hear from all of that local voice about what makes a difference. So if you can help us think about how we can design services that will make a difference to the well-being of your local people. So green spaces is a really good example of us working with our district councils to think about designing those in. We've had some really exciting work going on with some of the regeneration projects and helping building some of the wellbeing quarters. So it's great to hear that. I've got a slight blur, but local connection. So I think one of the things that fascinates me is the power of connectivity in our health and wellbeing. I think that some of the facts around loneliness and how it's actually loneliness is as big a contributor to ill health as smoking. We've got to empower our local communities to really value and appreciate and us as a health system invest in some of those opportunities. I think we've lost a bit of blurriness. Is it just my eyes after? I'm sure I'm not alone.
No, not your eyes. It's
no,
this is mine as well.
I'm afraid it'll be a slow connection for someone on the call and it's dragging it, but we'll sort it out.
So our understanding is this will stay live, so please do feed this in. Elliot or Nick, do tell me if I'm wrong, but does this stay open for a period of time? Can people still go on if the slides go out in the recording, or does it close?
It should stay open, so you should be absolutely fine to go for it. And if not, please do chuck it in the chat, or in fact just email them in, so we can feed it back in lots of different ways, whichever's easy.
Brilliant, thank you. And I think there is also in the slide deck an email address we would just like to really encourage, and we're reaching out to the community to build in community engagement opportunities. So please do email if you've got a community organisation that you'd really like us to come out and engage and talk with, because we're really committed to making sure that our services meet all of our local North and Mid community and design exceptional care for all of our local patients. Thank you.
Thank you very much. I've got 4 main sort of questions. So some of them have been sent to me offline, so I'll raise them as we go through. First up, I'm pretty sure I saw Dr. Alloway, Chief Medical Officer at Hampshire Hospitals on. I think I'll come to you first, if that's all right, which is to do with, I think it was Gwen about Andover MIU and sort of having to call an ambulance from outside the front of the hospital. If I could come to you to sort of explain what the system is and why that might have been.
Yes, thank you. Good evening, everyone. So in Andover, since the minor injury unit reopened, we're doing something called 111 First. So actually people have to have a booked appointment through 111 to be seen. So this is a pilot which is actually being really successful and means we're using that facility incredibly well. So I'm sorry that wasn't properly explained, but actually no one should turn up without an appointment. If they do, they should be supported and explained that they need to call 111 to make sure that if it is appropriate, they're seen in Andover. And 111 First is designed to make sure people go to the best place that can meet their needs. So we're trying to make sure if it is minor injuries or it is one of our EDs, that we give them a time to arrive, so that actually we can phase people coming into the waiting room. Obviously, if it is time critical, then that's a very different scenario, and either an ambulance will be called or they will be advised very differently. And I'm sorry, the 111 have been incredibly busy, and you can actually use the app. And I'm afraid with the pilot, there may well have been some teething problems, but it is working overall. It is working pretty well. And, you know, we're really keen to make sure that we use it, because we know that will use our services most efficiently. So people accessing them will have the best experience. So thank you, everyone who has, you know, sometimes they live in Winchester and they're advised to be booked in for an appointment in Andover, and people have found that great because they turn up at the time and they are seen. So thank you.
Thank you very much, Dr. Alloway. For the next question, it was sent to me offline, and it was a member of the public who's really struggled to get access to their GP and a face-to-face, wanted to know why this was and was it fair. It came up while Dr. Nesbitt was speaking, so if that's all right, I might come back to you.
Yeah, that's fine. I mean, I'm really sorry to hear that. I mean, I think the way that we work as GPs has changed enormously since the beginning of the pandemic. I'm aware that some people have had difficulties. I'm aware that some of the way that we've been working has not been popular. But a lot of it has been necessary, and a lot of it has been what we've been asked to do by NHS England. So I think somebody else mentioned earlier that the ask that as many appointments as possible were converted to kind of non-face-to-face appointments, and indeed the guidance from Public Health England, who advised us on COVID measures, is still that we should be doing as many appointments as possible by non-face-to-face means. And of course, there are people that we need to see face-to-face. As GPs, we have been carrying out face-to-face appointments the whole way through. I think probably the change is that at the beginning, the people that we were seeing face-to-face were people where it was strictly clinically necessary. So we've learned an awful lot. One of the things I've learned is that managing people with things like tummy pain is pretty much impossible on the telephone. You have to see them face-to-face. And I think what we're seeing now is people where it might not be strictly clinically necessary, but they simply prefer face-to-face appointments. They feel they have a better relationship with their clinician being seen in the surgery, and that's fine, actually. I mean, my kind of advice to people would be that if that's how you feel, it is fine to tell your doctor or the person that you're speaking to that is the case. And I think the vast majority of GPs and clinical colleagues would respect that. I mean, one of the difficulties that we have is that, of course, the buildings that we operate from were not really set up for managing large numbers of people with the kind of restrictions that we've had to live with. And indeed, if we cast our minds back to what GPs' waiting rooms tended to be like before the pandemic, I'm not sure that any of us would really want to go back to crowded waiting rooms, sitting very close to people we don't know, kind of coughing away without very many measures in place to reduce, to keep us safe. So I think it is about finding a kind of balanced answer. I think, as other people have said, it is about having a blended model moving forwards, but absolutely your GP surgery is open and they will see you face to face if you need to be seen or if you ask to be.
Thank you, Dr. Nesbitt. Very much appreciated. I'm not 100% sure I'm the right person to come to with this, so please bear with me. It's a question about the crisis in recruitment and retention in primary care and what's been done to alleviate it. So Ruth or Matt, is that either of you? I'm not sure.
Matt, do you want to kick off with the clinical side of things, and I'll pick up anything else after that?
Sorry, what was the question?
Around workforce in primary care. Recruitment and retention.
Recruitment and retention in primary care. Recruitment and retention in primary care has been an issue for a number of years. Back in 2015, the health secretary at the time estimated that the NHS was 5,000 GPs short of where it ought to be. And despite the best efforts of everybody, the number of full-time equivalent GPs has actually gone down since then rather than up. So there is a national shortage of GPs. One of the things that we've been doing to try to address that is to broaden the range of staff that work in our practices, and there has been some national support to do that. So, for example, in the practice I work in, as well as GPs and nurses, we also have physiotherapists, we have a pharmacist, we have a mental health nurse, we have a couple of people called physicians associates, we have a social prescriber, so a very broad healthcare team. And so the person that you speak to at the surgery might not always be a GP, but they will be a member of the team, and they will have access to your records. And we do all work quite closely together to make sure that people get the help that they need. With more you want to say, Ruth?
No, I mean, I suppose the only thing is that, we work really hard to make sure that our places and our practices are fantastic places to work, so that when GPs or other primary care professionals and clinicians have choices about where they'd like to work, we want to make sure we set ourselves up with partners and with others to make this the most attractive place possible. So both in terms of retaining people in our local area, but also attracting those small numbers of GPs who do move around the country and other professionals. And that's for all of us in terms of partners, to make sure that the setup we offer locally is as attractive and positive as possible. So, and a lot of the stuff that we talk about and that we do, that all of our colleagues today have talked about in terms of that partnership working, coming together around residents and populations to provide really fantastic services, I think all that really helps in terms of that agenda of being a really lovely place to be. So if we could bottle some of the stuff that we've talked about tonight, that we've shared with you, and stick that in an ad, I think that would do us the world of good in terms of ensuring our people feel really celebrated and supported to do their best work. So I think that's something else that we can all contribute to as well.
Thank you very much, Ruth. I did see a discussion going on in the chat about the use of plain English and why it's important, but I think it was quite well addressed, so I'll go on past that one. Question about the new hospital for Hampshire. So Alex, can I come to you with that one?
Yes, it feels strange to have had a couple of hours with our public and not talked about the new hospital at all. It's quite exciting in some ways. So the question was, is it really going to happen or not? So it has been announced on multiple occasions by Boris Johnson himself in the House of Parliament that there will be a new hospital in Hampshire. So yes, it's going to happen. I think some of the anxiety around the media bit is coming out of the fact that it is a national new hospital programme with aspiration to build 40 new hospitals, and there's some debate about what is considered to be a new hospital that some of you may have seen. But what's happening at the centre is they're really keen to manage this as a single programme that will deliver these 40 estates projects So we have been working on this since 2019. Well, you know, there were previous iterations, but this new hospital programme since 2019, and many of you have been involved in helping to shape what services we think we need in what location. We've been looking at location sites. You'll know that we're down to 2 options. One's the current Basingstoke Hospital site, and the other is just off junction 7 of the M3. And we've shared that all with the public, and we've been talking about that. We've been doing all this work so that we are ready. And at the same time, the new hospital programme team nationally has formed and come to talk to every individual system and say, where have you got to? What are you planning to do? What does it look like? How can we bring the benefits of a national programme to bear in order to be able to do 40 major construction projects as cost effectively as possible with some standardisation. So we're not all sitting there working out, you know, how big the toilet needs to be, but actually there is one way of doing that. And we'll end up with something that's bespoke for us, but also benefits from standardisation for a lot of the decisions, because actually, you know, a ward layout is a ward layout, and let's make sure we get the very best possible, and we don't all try and reinvent some of that. So that's where it is. We were hoping to be in consultation with the public about some of the service models, but we're just still in discussion with the national team about making sure that whatever we go out to the public with is aligned to the national programme. So it will happen. In the current plan, and the national commitment is it will open it will be built between 2025 and 2030, and that 5-year period. And we've been targeting around 2028, 29 for opening the doors. So that's the sort of timescales we're looking at. And I think the question there about, so people ask this, how can we start a new hospital? So the reality is that we need to provide care for a population of patients. So this won't be about creating lots more additional hospital capacity. In fact, what we're trying to do is, working with all our community partners, work out which of the patients who currently come to hospital could be looked after at home. So this will replace some of the existing hospital capacity. This isn't about saying we're going to need loads more staff in the hospital because we're suddenly massively growing the hospital capacity. It might need to grow a bit because we've got a lot of house building going on, we've got people aging, we've got more demand. We're hoping we can offset a lot of that by some of the digital technologies and the care closer to home. But yeah, I know sometimes when we talk about a new hospital, people think it's like a whole additional new hospital. It will replace some of the existing buildings which are no longer fit for purpose.
Thank you very much. I'm not seeing any other questions. So actually, Alex and Ruth, I'm going to stick with you for closing remarks, if that's all right.
Thank you. Do you want me to go first, Alex?
Go on then, Ruth, go on.
Okay, thank you. So just a really quick one, I suppose. So I was just making notes as we go through, and the thing that struck me is everything we've talked about is about services and fantastic opportunities to serve our population, but the thread that came through for all of that was our intention to work differently and much more together. And through all of the presentations we've talked about, I'm not sure that 3 or 4 years ago we'd have been able to tell such a coherent, consistent story across our partners and be able to describe so many contributions from so many people outside health as well as inside. So I think everybody talked about the voluntary sector, local government and other partners. And I suppose it just struck me as, you know, the NHS is a huge organisation, and the public sector at large is massive, but actually what it's all about is people and individuals making those connections. And I suppose that I'm just so proud that so much of the stuff that we do is around those connections and those relationships. So that ways of working thing, I think, has really shone through tonight, and I think a massive thank you to presenters for bringing that out as a key message for us. So thank you.
Yeah, thanks, Ruth. And I was, my scribbles were saying, I think there's a real theme about how we respond to individuals where they are at. So, you know, it came through in a lot of the digital side of it, that some people love a telephone call or a video consultation. Other people want to see someone face to face. And how do we make our services much more responsive to individual need? Bringing care closer to home and the COVID oximetry's work and things like the mental health safe spaces where we can create spaces where people can come that are in their community, but don't feel quite so much like coming into a healthcare facility. I think I also got a really clear message that we're not there yet. And thank you for all the people that said, look, this isn't working for me at the moment. And, you know, we've got a gap to close, because I think that really gives us energy to try and reprioritize and make sure we are closing the gaps that people experience when they experience our care. But absolutely, that whole joined up feeling. And then the other bit I had in terms of my hope for the future, or my confidence in the future, is just the innovation and the commitment and the passion and the dedication to trying to do the right thing for our people that just came through from all of the colleagues that we get to work with. And I think, you know, we've got such amazing people working in North and Mid Hampshire. And so the future's got to be bright, hasn't it? Because we've got incredible people committed to working together to do the best for the population. So massive thank you to all our speakers, been really inspirational to hear from everybody. And thank you for all our public who have come on to ask their questions. And I'll just hand back to Elliot to close out. Thank you.
Thank you very much. On that, there is actually one last question, but Colin, if we don't mind, we'll pick it up separately if that's all right, because rather than sort of reopening the whole thing, but we will get to it, I promise. Thank you everyone for coming out. Thank you so much to all our speakers for making time. This will be shared, so we will be making this available both in its whole form on YouTube. It'll be on the Hampshire Hospitals and Clinical Commissioning Group websites. It'll also be shared via social media. And we're also looking to break it down into sort of 10-minute bite-sized chunks, almost like a lecture series, which can be shared and digested to your heart.